Welcome, I'm Don Renfrew, and for the next hour or so I'm going to be speaking about pediatric imaging. I'm a radiologist with Radiology Associates of the Fox Valley. I practice general practice radiology basically and serve a number of primary care practitioners. As such, I'm not a pediatric radiologist, but I'm trying to cover today some general information that would be of interest to primary care practitioners who do see children in their practice. I practice predominantly at Door County Memorial Hospital in Sturgeon Bay, Wisconsin. Door County Memorial Hospital is located on the Door Peninsula between Green Bay and Lake Michigan. It's a small hospital, a rural hospital. It's a critical access facility. It's about 50 miles from the nearest other hospital. And I'm the radiologist that services this hospital. My group is a large group of over 30 members that covers 8 additional hospitals in central Wisconsin, but I mostly work at Door County Memorial Hospital, where I'm the director of radiology. In addition to my job as director of radiology, I'm also the director of a monthly Grand Rounds conference, and as such I have made a series of lectures that have to do with what imaging study to order in what clinical circumstances. These lectures are directed toward primary care practitioners. Now, in times past, most primary care medicine in the United States, or at least a large percentage of it, was performed by family medicine physicians or internal medicine physicians. As time goes on, internal medicine physicians are more and more migrating into becoming hospitalists, or all becoming subspecialty trained in cardiology and nephrology and gastroenterology, etc. Family medicine physicians, there are fewer and fewer U.S. medical school graduates going into family medicine, and while there are foreign medical graduates filling in some of those slots, in other cases the slots may go unfilled and there may not be as many family medicine physicians graduating in times to come. Because of that, nurse practitioners and physician's assistants may be doing more of the family practice or the primary care for many United States citizens as time goes on. And this talk is really for any primary care provider that orders radiology studies, or indeed for any medical practitioner that orders studies that's maybe outside of their exact area of expertise. This is kind of an introductory talk about radiology. This talk is not going to tell you so much how to read studies as to what study to order in what circumstances. Now, you have many options for imaging pediatric symptoms: plain films, ultrasound, CT, nuclear medicine, MR, etc. At the same time, you want to order the right study the first time, every time, particularly if it's a radiation technique. You don't want to, needless to say, radiate children. And even if it's not, imaging can be expensive, and you want to do the right thing by your patient. To this end, I'm going to review imaging of pediatric symptoms for the next hour or so. Now, the lecturer is going to briefly review that topic, but the first thing I'd like to note is that because of the nature of diseases of children who come to see primary care providers, or for that matter, even a general pediatrician, the number of radiology exams is typically far fewer on a per patient or per exam, per patient visit basis than in the adult population. Kids tend to have different diseases than adults. So what I'm going to talk about is a few of the more common clinical scenarios where children will be sent to imaging. But in general, there's probably less imaging done on kids. Most of the kids' disease processes are worked up and managed without imaging. So in that regard, all imaging that I do, only a small amount of it in a general radiology practice, only a small amount of that imaging is pediatric imaging. Now, as I said, I'm not a pediatric radiologist. What I would like to say is that entire books have been written on this topic, and these are a couple of those books. This lecture can only give you a brief overview of 6 of the most frequently encountered or clinically important situations where imaging can come into play. If you would like a more in-depth discussion of pediatric radiology, there are two excellent books that are out there. One is Lane Donnelly's Fundamentals of Pediatric Radiology. It's less expensive and it's really short enough to read all the way through. Hilton and Edwards' Practical Pediatric Radiology is considerably longer. It's a very good book, but it's, unless you're, for example, going into pediatrics, you probably wouldn't read that book in its entirety because it's a fairly long book, but it's quite good. Those are your two choices if you want additional material to read other than what you're going to hear in this lecture. What are my points in this lecture? Well, again, I'm going to try to cover 6 general scenarios where pediatric imaging is a reasonable thing to do. First is that a 2-view chest may help you in evaluation of a child with cough and fever, or in a child with a fever that has no localizing signs or symptoms. Second point is that a barium study or an abdominal ultrasound may be performed in a neonate with persistent vomiting. Third is that in a young child with bloody stools, intermittent abdominal pain, and a palpable abdominal mass, or any combination of those 3 features, you should probably consider emergency surgical consultation. Plain films and ultrasound of the abdomen may be followed by an attempt at intussusception reduction. The fourth point is that CT exam of the abdomen and pelvis may be obtained for a child with a right lower quadrant pain, loss of appetite, nausea or vomiting, fever, and an elevated white count, in other words, symptoms of appendicitis. It's not always necessary in appendicitis, and I will discuss that here when I review these different points individually. A CT exam of the sinuses and orbits may be obtained for a child with a runny nose when they have additional features like a headache and visual symptoms. And finally, plain film exam is usually your first step for evaluation of swallowed foreign bodies, especially if the swallowed foreign body is known to be composed of metal. So, each of these points, these major 6 points, I'm going to review in some depth, not a great deal of depth, but in some depth. And each of these is going to be on a red slide to help you remember that this is the important thing, and I'll try to hit these points 2 or 3 times through the lecture. So the first issue is 2-view chest may help you in the evaluation of a child with cough and fever. Chest radiography is widely used in the evaluation of pediatric patients with lower respiratory tract infections, but there is some controversy involving the routine use of chest x-rays. Some studies have suggested that it doesn't really affect the clinical outcome of children with pneumonia one way or the other. The value of chest radiography is based on the ability to help distinguish between the various causes of pneumonia and also to diagnose complications, as well as to exclude other causes of pneumonia symptoms. So what are those causes of pneumonia? Well, with respect to the causes, most pneumonia is viral, but there are important age differences. In patients from about 3 months to about a year, 95% of your pneumonia is going to be viral. For patients between 1 and 5 years, RSV, or respiratory syncytial virus, accounts for about half of the pneumonias. And for school-age children, ages 5 to 18, the atypical pneumonias, mycoplasma pneumonia and chlamydia pneumonia, will predominate. What are the patterns? Well, chest radiographs can broadly be categorized as showing one of 3 patterns. An interstitial pattern with linear strands of density radiating from the hilum, parabronchial cuffing, and fat hilum or enlarged hilum. The second pattern is alveolar or airspace with a dense white parenchyma and air bronchograms and a segmental and lobar distribution, often with an accompanying or sometimes with an accompanying pleural effusion. And finally, there's a mixed pattern, which is some combination of those other 2 patterns. As a generalization, the interstitial pattern predominates in viral pneumonia. The alveolar pattern is seen with infection from typical bacteria like Staphylococcus or Streptococcus. And a mixed pattern is seen with your atypical organisms like Mycoplasma and Chlamydia. Of course, if you have a viral pneumonia with a superimposed bacterial pneumonia, you can also see a mixed pattern with that. What are some examples? Here's a 2-year-old with cough, shortness of breath, and in all likelihood, viral pneumonia. Here's a frontal chest radiograph that shows some streaky densities radiating from the hilum, and I've got arrows on these. Of course, chest radiographs, it's hard to take a picture and translate that over into a PowerPoint slide and project that and have that transmitted over the internet or onto a DVD. So some of these findings are subtle enough that they may be difficult to see and even questionable when you're looking straight at them. But in the original chest x-ray, you could see there were some streaky densities. The other things that you could see in this child is that the lateral study showed hyperinflation of the lungs with flattening of the diaphragm, along with somewhat prominent hyla. Here's an arrow indicating that flat diaphragm that we talked about. And here's a composite in this patient that got better without antibiotics, but did have symptoms of a pneumonia and radiographic features of a viral pneumonia with an interstitial pattern. Again, that streaky densities radiating from the hyla, plump hyla, flattened diaphragm, hyperinflated lungs. So, how about the alveolar pattern? Here's a 15-year-old with cough and fever. And what you're going to see here is focal abnormal densities in both the medial right base and along the heart border at the left base, here demonstrated by the arrows. On the lateral exam, you'll see that there's abnormal increased density not only over the heart along the interaspect, but also increased density over the mid-thoracic spine. Usually the vertebral bodies will become more lucent as you go from the apex to the base of the chest, but in this case there's increased density over those vertebrae in the mid-chest. Here you can see an arrow pointing to the increased density over the heart shadow in the front, and also arrows surrounding that area of increased density in the posterior chest, with the vertebral bodies kind of being whited out, so to speak, as you go down that lateral chest exam. So that's a typical bacterial pattern of pneumonia, which did get better with antibiotics. The mixed pattern, here you've got a 3-year-old with fever, cough, and dyspnea. In this case, the frontal study shows both prominent hyla, streaky densities, and abnormal opacity in the right mid-lung. Some of that can be accounted for by the scapular shadow, but it's not all scapular shadow. Here the arrow shows you that increased density in the right lung. And here the lateral study, again showing you a plump hyla and somewhat hyperinflated lungs. It can be hard to tell whether that vague density is consolidation from atypical pneumonia, superimposed bacterial infection, or even some atelectasis. Here's a composite view of those two pictures. It's an abnormal chest x-ray, but it's really kind of a mixed pattern. So, while it's true as a generalization, the chest x-ray doesn't do as good a job of the distinction between interstitial, mixed, and alveolar as many of the textbooks would have you believe. And this is secondary to a number of factors, including the inter- and intra-observer variability. In other words, if I look at the same chest x-ray 3 days in a row, there's some variation in how I read it. Me versus any one of my 30 partners, there's some variation between us. So there's going to be variability in interpretation of radiographs. And because of that variability, also because of the overlap between radiographic findings and cause, and the fact that the radiographic findings can lag behind the disease because of dehydration, you don't really have a one-to-one correspondence between radiographic features and the exact viral atypical pneumonia, typical pneumonia correlation there. So the chest x-ray can't be used in isolation to make the determination whether a patient's pneumonia is really viral, atypical pneumonia, or typical bacteria pneumonia. Again, one of the reasons to do the chest x-ray is to look for alternative causes. It really has a lot of value in excluding alternative explanations of cough and tachypnea, such as a retained foreign body. You usually want to obtain an inspiration-expiration film to see if there's air trapping behind that foreign body. You can see congestive failure with a big heart, fat pulmonary vessels, pulmonary edema. You can diagnose complications of pneumonia like the development of a pneumothorax from coughing or a pleural effusion, empyema, pneumatocele, necrotizing pneumonia, and lung abscess. So these performance features in radiographic evaluation are helpful in certain circumstances, like when the child's really sick or when the child's likely to be admitted to the hospital. This child wasn't really sick, but did have asthma and a cough. And what you're seeing here is that the normal thymus is separated from the heart border, as you can see with that arrow. On the lateral study, there's actually some abnormal lucency just anterior to the heart along the interior of the chest, just beneath the sternum here at the arrow. And this is a pneumomediastinum caused by coughing in this patient with asthma. That can be a cause of pain. And typically these patients are kind of followed to make sure that that resolves, doesn't become more severe in terms of a pneumothorax or enlarging pneumothorax. Okay, the other time where you can actually make use of chest radiography is when patients have a fever even if they don't have a cough, if they have a fever and a high white count, they may have pneumonia. They may not have any localizing features. There was one study that showed of 146 children with fever and no clinical signs or symptoms of pneumonia and a white cell count of over 20K. 26% of those children had radiographic evidence of pneumonia. So, as a way to search for occult pneumonia in patients with obvious infection or suspected infection, it's probably a reasonable thing to do. So that's the chest x-ray issue. Again, typical patterns, interstitial, more of a viral pattern, mixed, atypical pneumonia, lobar alveolar consolidation, more of a typical bacterial pattern, and obtain a chest x-ray with suspected occult pneumonia because of fever and elevated white count. All right, next step, or the next study rather, we'll talk about is an abdominal ultrasound or a barium study performed in a neonate with persistent vomiting. Now, what about vomiting in children? A few comments regarding vomiting in pediatric patients in general. As a generalization, it's usually best to involve an appropriate specialist, like a pediatric gastroenterologist or a surgeon or a neurologist, earlier rather than later in cases where there's a lot of vomiting. Now, what's a lot of vomiting? Well, a prolonged vomiting is a lot of vomiting. That's greater than 12 hours in a neonate, greater than 24 in children under 2, greater than 48 in children over 2. Other features that are worrisome in vomiting include features of obstruction like abdominal distension, visible bowel loops, marked change in bowel sounds, bilious vomiting. Other features, central nervous system cause, like nausea with awakening or vomiting with a change in position. And finally, things like hyponatremia, out of proportion with the illness, and marked hyperkalemia. Those can represent an adrenal crisis. So those are things that should make you think about working out vomiting sooner rather than later. How about neonatal vomiting? Well, in neonates, the main things you're thinking about are normal spitting up, gastroesophageal reflux, idiopathic hypertrophic pyloric stenosis, malrotation, and duodenal stenosis or atresia. Normal spitting up and GE reflux usually don't need imaging. If the child has most of the classic features for idiopathic hypertrophic pyloric stenosis, and those would include a presentation between 3 and 6 weeks, postprandial non-bilious projectile vomiting, desire to feed shortly after vomiting, in other words, a hungry vomiter, and a firstborn male status, usually your best first step is going to be ultrasound. And you want to do that in a fasting infant who's fed either water or electrolyte replacement solution. The ultrasound study should demonstrate either a normal pylorus or an abnormal pylorus, which may demonstrate, if it's abnormal, abnormal wall thickness, abnormal length, or overall volume, abnormal volume and diameter. Here's a 3-month-old with persistent projectile vomiting in a normal study. The ultrasound exam through the mid-abdomen after oral administration of water shows a normal antrum in A, and then in B, the ultrasound exam, by being obtained under constant observation, demonstrates fluid in the distal antrum and then the pylorus and the duodenum. The arrow shows the margins of a normal duodenum in B there, so that's all good. Now here you go as a 2-month-old with vomiting and weight loss, and the picture in A shows a longitudinal view of the pylorus between the caliber. It's abnormally long and it's abnormally thick walled. And then your ultrasound in the transverse view shows an abnormally thick wall. And I'd like to thank my partner, Dr. Jeff Sapolsky, for loaning me this case for my talk here. Now, if the patient really doesn't have the typical clinical features, or if the ultrasound doesn't really settle the issue, then you can do an upper GI. You're really looking for prompt emptying of the stomach, and you're looking for either gastroesophageal reflux or not. Probably the most important thing to look for is the location of the ligament of Treitz, or the transition from duodenum to jejunum, and that should be in the left upper quadrant. It should be to the left of the spine, should be superior to the duodenum, and if you don't see it up there, then you have to think about the issues of malrotation with associated risk, which could lead to infarction. So that's the time when you do, you go on from the ultrasound typically to the upper GI. The ultrasound you usually do first, less radiation, almost always diagnostic. If it's equivocal, or if you really are thinking about malrotation more than idiopathic hypertrophic pyloric stenosis, then you may need to do the GI rather than ultrasound. Okay, so that takes us through the neonate that's vomiting. How about a young child? Bloody stools, intermittent abdominal pain, palpable abdominal mass. I mean, if you have two of those three, if you especially have all three, you're really thinking in terms of an intussusception, and you really should be talking to the surgeon sooner rather than later. Now, the typical clinical features will usually be seen in less than 15%. This is a diagnosis seen mostly in younger children. About 90% will occur before the second birthday, usually between 5 and 9 months. Now, why do you want an early surgical consultation? Well, even if you diagnose intussusception and treat it in the radiology department, you need to evaluate it with the idea in mind that immediate surgery will be performed if you can't reduce the intussusception, or if you perforate the child when attempting intussusception reduction. So you have to have a surgeon kind of standing by to make sure that this case can be handled in the event of something bad happening. Now, what about imaging? In most cases, plain films and ultrasound, and these can be ordered prior to surgical consultation where there's a lower suspicion of intussusception. They're going to be necessary anyway for diagnosis. Plain films can document dilated small bowel loops, and sometimes see an obstruction, often indirectly because it's draped around, the dilated bowel loops are draped around the mass. Free air on plain films is a contraindication to enema reduction. Typically, patients with free air have a perforated viscus, and usually you're thinking in terms of an operation for those patients. Ultrasound may show you a characteristic so-called bullseye or coiled spring appearance. If there's no free air, but there are ultrasound findings of intussusception, or if there's no free air but the clinical features are felt to be classic, then enema reduction may be attempted. The method of reduction varies with the local expertise and experience. It can use either ultrasound guidance with rectally administered air or saline, or fluoroscopic guidance with rectally administered barium or water-soluble contrast material, something that shows up on X-ray. As is usually the case when you've got this many alternatives, and one hasn't really replaced all the other ones, there are advantages and disadvantages of each alternative. And there's usually a good reason, or several good reasons, why a particular radiology department chooses to treat intussusception in the manner that it does. So when you have a suspected intussusception, you're usually going to contact both the radiologist and the surgeon, and they'll kind of work out together what they usually do in that department for those patients. So that's the issue with intussusception. What's next? Well, next would be a little older child perhaps. For a child with right lower quadrant pain, loss of appetite, nausea, vomiting, fever, elevated white count. Many of the pediatric patients with these features will be older than 5. The diagnosis is often straightforward, especially if you have all those typical features. And the case in that instance is usually just to contact the surgeon and let them take over from there. Now, if imaging issues to consider in patients with suspected appendicitis include, number 1, is imaging necessary? Number 2, if it's necessary, what modality do you use? Some sources recommend early consultation with surgery, and the surgeons make the decision about whether the clinical scenario is typical enough to go right to surgery, or if you need to do imaging. If you do go with imaging, then your choices are basically ultrasound and CT. Ultrasound is usually used where you've got a local expertise and in the performance and interpretation of the exam. It's a demanding task, and it really requires a considerable skill and extensive experience on the part of the tech and radiologist, and it may not be available in all departments. The exam is somewhat prone to false negatives when performed by those who are less than full-fledged experts. And in that case, a negative study can't really be relied on to confidently exclude the appendicitis. Even the positive studies you may follow with another study, so you really have to wonder if you just add the expense and time to the workup of the patient. However, if your department is really good, or if who you're using is really good at diagnosing appendicitis with ultrasound, by all means it has been used in that manner. At any rate, CT is the other exam. If ultrasound, if you're going to use CT, you can use it to confirm the ultrasound, or you can just use it from the beginning. I will say, though, that ultrasound has a big advantage in female patients, because if there's any suspicion of gynecological disease like ovarian torsion or hemorrhagic ovarian cyst or pelvic inflammatory disease, those processes can mimic appendicitis, and ultrasound is pretty helpful at excluding those processes. Okay. Now, having said all that, if we end up doing a CT, there are a bunch of things to think about when you're, when you're going with a CT in a patient with appendicitis in a pediatric patient. Someone is going to have to decide how the exam is going to be performed. Of course, in all cases involving ionizing radiation, but especially in pediatric cases, radiation dose is becoming a more and more important factor in deciding how to perform the imaging. You want to optimize the technique to use the lowest possible radiation dose, and you typically achieve that optimization by reduction in the tube milliamperage and increased pitch with the helical scanners. Of course, the more passes, the more times you go through the abdomen, and the larger area covered, for example, the whole abdomen pelvis versus just the pelvis, the more ionizing radiation is used. So, what are different ways of doing CT scanning? There's several. You can scan without any contrast at all. That's called a CT-KUB, and you usually use that alternative when you're really thinking it could be a urethral calculus or a renal calculus. Advantages include you can have an immediate scan without any oral, rectal, or IV contrast. The disadvantages is that you may not get a fully diagnostic scan, especially if the patient is really skinny. You don't have the natural contrast provided by the fat in the peritoneal cavity, which can surround the cecum and appendix in fat people, or even normal people. If that happens and you get a non-diagnostic study, you wasted time, energy, expense, and radiation dose. And you're going to have to give the patient some contrast. Another alternative is to give IV contrast and scan only with IV contrast. In this case, you can have a rapid scan. You've avoided oral contrast. Those are good. The disadvantages include that sometimes IV contrast can obscure small renal stones, and the distal small bowel is not going to be real well seen necessarily with just IV contrast. Usually, if there's an obstructing renal calculus, you'll have secondary signs like hydronephrosis and perinephric stranding. So all is not completely lost with IV only in renal stones. In addition, you can run a level of study and see the stones usually, even if you have IV contrast in there. So, first option, no IV or oral. Second option, IV only. Third option, oral and IV. Okay, now the disadvantages of this is it's going to take longer, at least an hour, maybe two, before the terminal ileum and the proximal colon has enough contrast to really see it well enough to make a good diagnosis. The advantages are that it allows a better evaluation of the distal small bowel, and sometimes you can make alternative diagnoses like gastroenteritis or Crohn's disease as opposed to appendicitis as the cause of the patient's symptoms. Finally, you can scan with rectal contrast either with or without IV contrast, and it has a pretty high accuracy in the diagnosis of appendicitis, but patients don't like it, techs don't like it, and while the large bowel and appendix can be well seen, and the technique's really pretty accurate in characterization of the appendix, contrast material may not reflux into the small bowel very much, and you can miss diagnoses of the small bowel, like Crohn's disease and gastroenteritis. So, As you can tell by all these alternatives, there are multiple considerations in play. In your particular case, is it best to minimize radiation and maximize diagnostic yield, especially if there's other alternatives to appendicitis? Then you may want to do a single pass 2 hours after oral contrast with IV. Is it necessary to obtain an immediate diagnosis to the best extent possible, and is your ureteral calculus a strong consideration? Well, you probably want to just do an immediate non-contrast study. Of course, the immediate non-contrast study may be diagnostic, and then you added additional radiation time and expense because you're going to have to now do oral and IV later. These considerations show why there is a lot of variation from one department to the next as to the timing, amount, and type of contrast that is given for patients with appendicitis or for other GI conditions for that matter. Now, as far as imaging findings per se, the imaging findings are the same in pediatric patients as you see in adults, and those include appendiceal swelling, thick wall of the appendix, abnormal contrast enhancement of the appendiceal wall, inflammatory changes in the periappendiceal fat, such as seen in this 6-year-old boy with abdominal pain and nausea and vomiting. The arrow shows you a thick wall, intensely contrast enhancing appendix and some periappendiceal fat stranding. In those patients where the process has progressed and the appendix is ruptured, there's going to be a disorganized appearance in the right lower quadrant because there's going to be leaked fluid and secondary inflammatory change. Here you have a CT with kind of loculated pockets of fluid, a lot of inflammatory stranding, and a very disorganized appearance of the bowel here between the arrows in this patient who had a ruptured appendix. He was actually a relatively stoic 16-year-old who had a crescendo of pain which then somewhat abated and over the next several days had ongoing pain. So he probably had appendicitis rupture followed by some at least partial relief of pain and then ongoing inflammatory changes in the perineum. And the surgeons will tell you that it's a real mess when they get in there and try to clean this up because they've got inflammatory change everywhere and it's a little hard to see what's going on and try to fix it at that point. And it can lead to adhesions, of course, later on. So it can be a tough disease to treat once it gets to that point. So if you have, nausea, vomiting, increasing pain, loss of appetite, especially if it's starting to localize to the right lower quadrant, you're better off getting that taken care of because you really don't want to rupture. Okay. Another clinical scenario is a child with a runny nose, fever, headaches, and development of visual symptoms or any CNS type symptoms. You want to think about upping the ante and imaging that. And what about sinusitis in pediatric patients? Well, it has similar symptoms to sinusitis in adults. You can have a persistent runny nose, you can have sinus congestion, you can have sinus pain, you have some fever. Viruses are going to cause most episodes of sinusitis. About 10% of the viral infections have a superimposed complicated acute bacterial sinusitis on top of that. And when that occurs, the patient will usually either have an exacerbation of ongoing symptoms or a better worsening picture where they're bad, they get better, and then they get worse again. Or sometimes they'll just have prolonged symptoms like 10, 20 to 30 days. Now, imaging, whether it's plain films or CT, can't really tell you whether it's viral or bacterial sinusitis because both of those processes produce mucous membrane thickening and air fluid levels. The American College of Radiology and the American Academy of Pediatrics do not recommend imaging patients with typical straightforward sinusitis. You're not really going to be able to tell which of the two processes it is. And by and large, treatment is symptomatic. It's hard to treat someone with sinusitis without antibiotics, but a lot of the recommendations are to treat symptomatically and supportively rather than with antibiotics unless there's some sort of complication or high fever. Now, speaking of complications, there are certain dreaded complications of sinusitis, and you're usually tuned into the fact that those may be occurring by symptoms on the part of the patients. The complications involve spread of the infection from the sinuses to the orbits, in which case you get orbital cellulitis, or into the cranial vault, where you can see several things like septic cavernous thrombosis, meningitis, osteomyelitis of the frontal bone, epidural abscess, subdural empyema, and brain abscess. All these are bad things that can happen to kids with sinusitis, and then they manifest as the child becoming worse, having a worse fever, having a severe headache, having visual symptoms, etc. Any kid with sinusitis that then has orbital cellulitis, or pain with eye movement, or limitation of eye movement, double vision, vision loss, ptosis, proptosis, headaches, altered mental status, neurological signs, neck stiffness. These are all kind of things that should make you think in terms of upping the ante, getting some imaging on a patient with sinusitis. What imaging do you get? Well, CT of the brain, including scans through the base of the maxillary sinuses, is probably going to be your best first bet. You could perform that with thin cuts. That allows multiplanar reconstruction to better visualize the sinuses, and also probably IV contrast, because you want to look for any contrast-enhancing areas of inflammation. CT is much faster with helical and multi-slice scanners than MR, and for a kid, especially if they're sick and don't feel like sitting still, or it's difficult to get them to sit still for any length of time, the CT is a good study. You can do MR of the brain, and of course it shows that soft tissue anatomy brilliantly, and it can be very helpful. You usually perform it without and with contrast. The issue there is getting the kid to hold still long enough for good pictures. The cross-sectional exams, basically you're looking for differentiation between preorbital cellulitis and orbital cellulitis, and those distinctions are necessary to facilitate rapid treatment with patients with severe complications of sinusitis. All right. Okay, let's talk briefly about the plain film evaluation in kids with foreign bodies. Let's take a simple case first. Kids, first of all, kids will swallow almost anything. The most frequent swallowed entity is a coin. Recommendations in up-to-date are to obtain two-view AP lateral examination of the nasopharynx or neck, chest, and abdomen. In other words, mouth to anus, AP, and lateral views. When I talk to emergency room physicians and pediatricians, they seem to indicate that that's probably overkill, and frankly, the practice in our department is to do what the clinicians ask us to do, and they usually ask us to do an AP view of either the abdomen or the chest and abdomen in those cases where there's been a swallowed coin. If your AP film shows a coin, if it's a coin that you're looking for, and if the AP film shows a coin in the stomach, in most likelihood that's going to pass. And unless the patient becomes more symptomatic, then additional imaging is probably additional radiation exposure expense you don't really want to put the kid through. So in this first case, this 3-year-old who swallowed the coin, you see the coin in the stomach. This kid didn't have any other imaging, and it passed through the GI tract uneventfully. Some parents are worried, concerned, want to look at the stool for the coin. Other parents think that's the most ridiculous thing they've ever heard. So, that'll vary. But basically, often, unless the kid gets symptomatic, becomes constipated, has abdominal distension, starts to vomit, really gets fussy, you kind of think, well, good, the coin's in the stomach, let's go on from there. In this second case, you also have a 3-year-old who swallowed a quarter. The initial AP view of the abdomen did not show the quarter. And in this case, we're going to pursue it a little further, and we saw the quarter very proximally located above the thoracic inlet, actually. And that's got to be in the proximal esophagus, hypopharynx, and it's hard to believe that's in the larynx, because you'd think it would obstruct the larynx. At this point, it was recognized that there was an emergency, and the kid was transported to have flexible endoscopy and removal of that. I think the coin probably moved between this picture and the time it was taken out, because it was actually in the trachea when it was taken out. At any rate, so in that case, it was proximally located. Now, I don't have a picture of it, but another case I will talk about briefly is I was on the phone with a surgeon in my hometown, in my first practice in Ottumwa, Iowa, And I was talking to him about something entirely unrelated he called me about. And my then 2-ish-year-old son, George, was wandering around with a penny in his hand, and I didn't say, George, put the penny down. I kept talking, and then I noticed George didn't have the penny in his hand anymore. So I said to the surgeon on the phone, I think my son just swallowed a penny, what should I do? And the surgeon said, well, is he in any distress? So I said, like what? He said, well, is he spitting up? And I said, yeah, he's spitting up. So we took George to the emergency room and did fluoroscopy, and the penny was actually in the esophagus above the gastroesophageal junction. Now at that time, 20 plus years ago, when you had a patient, a child like that with a coin in the esophagus, some radiologists would actually take a Foley balloon catheter and slide it either through the nasopharynx or oropharynx into the esophagus, pass it beyond the coin, blow up the balloon on the tip of the catheter and pull it back. Now, subsequently, it's been found that provokes fatal vasovagal reaction, vasovagal reaction in some children. And so that's kind of fallen out of favor for obvious reasons. Interestingly, we had George kind of all signed up, so to speak, for this procedure, and I had the Foley catheter out, and about the time we started with figuring out how to keep him from biting the Foley catheter until we performed fluoro again, and the coin had gone into his stomach. I was not in the camp of parents who diligently examined the feces for the passed coin. It did pass it uneventfully, at least we assume. It was not on the CT scan we did for George when he was 13 and had appendicitis. So at some point between those two exams, it did pass. Anyway, that's kind of a lengthy aside, and we'll kind of push on here. Foreign bodies, when not to worry. Well, in general, coins, folded paper clips, other small metallic, non-metallic objects in the stomach, they'll probably pass sooner or later. Longer objects, like 5 centimeters is long, 10 centimeters is real long. Sharper objects, they're going to be less likely to pass. And so if you know that the patient swallowed a toothbrush, then you're probably going to have to retrieve that with fiber optic endoscopy. Although if it gets as far as the stomach, maybe not. Objects that are clearly stuck in one place or have a sharp edge on them, they're going to have to come out. If you have the kid and they have difficulty swallowing, if they have fever, if they have vomiting, you're going to have to consider removing those. Lead objects like those sinkers that they use in fishing tackle and other things with lead, you want to get those out sooner rather than later, because believe it or not, lead poisoning does not take that long to develop when you have a lead object inside the gastrointestinal system. The topic of battery ingestion could easily fill a lot of time and is its own little entity, but basically, what's interesting about battery ingestion is that on those batteries there's actually some little code letters that tell you how big the battery is and what the voltage is and their construction, lithium, silver, etc. There's a hotline for poison ingestion, and they also know about all the poop on batteries on that hotline. But I think the main thing to keep in mind is that the big ones, like the 20 millimeter jobs and the ones that are larger than that, they're going to have trouble passing through the distal, the gastroesophageal junction, especially on smaller kids. So those you got to worry about if you know it's a battery that big. Batteries do have certain radiographic characteristics that allow you to separate them from coins, mostly in what they look like at their edge, if you don't know which one of the two it is. And then finally, what's real interesting is that batteries, even relatively discharged batteries, if they're in the esophagus can complete the circuit. In other words, there's contact on both sides of the batteries, and the current going through the esophagus from one pole to the other one of the battery can incite coagulation, necrosis, and perforation or adhesion or stricture or other problems of the esophagus. So that's the deal. If the battery is stuck in the esophagus for any length of time in one position, it can damage the esophageal mucosa because of the electric current induced. So that's its own little topic. But basically, if a button battery gets into the bowel, less to worry about. The other thing is that if you swallow multiple batteries, or if you swallow a battery in a magnet, even if it's in the bowel. It can cause volvulus through the things sticking together. At any rate, so that's the foreign body issue. So what I've talked about here is just a few of the more commonly encountered and clinically important scenarios in pediatric patients that could be seen by a primary care practice physician in their usual course of business. Mainly the chest x-ray for cough and fever, or in a patient where you think they might have occult pneumonia because of fever and elevated white count. If you have persistent vomiting in that neonate, remember those features of persistent projectile vomiting, a hungry vomiter, a firstborn male status, etc., then you usually want to do ultrasound first to figure out whether they have pyloric stenosis and the palpable olive and all that stuff. If you're thinking more in terms of malrotation or duodenal atresia, you probably need an upper GI. And sometimes you do the ultrasound first, and then depending on the results of that, go to the upper GI. In the rare occasion of intussusception, you'll have some combination of features like bloody stools, intermittent severe pain, abdominal distension, palpable mass, associated imaging findings. And again, you need to have the surgeon involved even before the reduction attempts typically, because they may be needed and they need to be ready to go and they need to know about the patient. For right lower quadrant pain and features of appendicitis, CT can be done. As I mentioned, CT was done in George, who had not only the penny in the esophagus but also a bout of appendicitis. It was diagnosed with CT, and in his case it was done, the CT was diagnostic despite the fact that at that time he was 5'8", 130 pounds and probably 5% or so body fat. He was a very lean kid, and we didn't use any oral or IV, but there was a swollen appendix which measured 13 millimeters and some free fluid, which was enough for the diagnosis. So otherwise, the decision about whether to give oral and IV and how much and when, I kind of went through those. There's some quandaries there to discuss. CT of the sinuses and orbits when you've got sinusitis, which is suspected to be complicated with orbital infection, and again, if they have visual symptoms, then you have to think about that. And finally, the plain film evaluation for foreign bodies. If the foreign body that the kid's taken in isn't metallic, your choices are, if you think it's in the lungs, if they got stridor and difficulty breathing and you think it's in the lungs, probably doing a chest x-ray, inspiration, expiration will help, because then you can see if it's trapped on one side of the lung and it's trapping air. If the kid can inhale deeply and get a nice bilateral, full, open lungs, can exhale and one lung collapses and the other stays inflated, then you know that the foreign body is in that bronchus, and they can go after that with the fiber optic bronchoscope. If you think there's a radiolucent foreign body, either in the lungs, tracheal tree, tracheobronchial tree somewhere, or in the esophagus, then a CT is probably going to be a better bet, because it can see things that you can't see on the plain film. So plain film for foreign bodies when they're metallic, CT probably when they're not, and you really have to know where they are and what they're doing. So those are some general rules for pediatric imaging. I hope you find them helpful, and that you find this talk will give you some benefit when you're taking care of the kids. Thank you very much.